So thanks again for the introduction, and we'll skip to the first slide here. Fortunately, this event was held this week, not last week when we had NATO, and I'd like to point out that the gentleman on the far right is my physician assistant's father, and he's just around the corner. So if anyone gets out of line, Sergeant DeDore will be here momentarily. So I practice at Rush, also at Central DuPage Hospital. I'd like to acknowledge Lee DeDore, my PA, for helping with the presentation, Paul Strandquist for organizing, and also Maritza for keeping me abreast of everything that I needed to do to be here today. So when we talk about distal biceps tendon disease, the vast majority of time we're talking about ruptures. There's typically an element of degeneration or tendinosis, which precedes a rupture, and the differential diagnosis is pretty limited. You're either going to get a rupture, a partial tear, tendinosis. Oh, is that better? Okay. Or you can get a bursal inflammation or bursitis of the cubital fossa. So many of you, or if not all of you, have seen a patient like this who presents with ecchymosis, medially retracted muscle, or medially and proximally retracted muscle belly. It's quite clear that he's completely ruptured his distal biceps tendon. Oftentimes you can palpate the tendon stump in the cubital fossa, and you can visualize the proximal migration of the muscle belly. Patients experience a tearing sensation and oftentimes a pop. It's a relatively rare injury, but it's thought to be increasing in frequency. There's some association with anabolic steroid use, but this is not generally the case in our patient population. Most commonly, the tendon tears off of the radial tuberosity or the bone. I'll show you images of that later on. So a brief background on anatomy. The biceps tendon obviously occupies the majority of the anterior arm. It's got two muscle bellies and two heads, biceps. The origin of the long head of the biceps crosses the shoulder joint, and the short head only crosses the elbow joint. It does not cross the shoulder joint across the interarticular space as the long head does. It does still cross the joint, however, anteriorly. It's innervated by the musculocutaneous nerve, C5, C6, and the main function of the biceps tendon is supination strength. So common activities in supination would involve opening a doorknob. So biceps flexion actually is controlled more by the brachialis and coracobrachialis muscles. So you can tear your biceps and still have pretty good flexion strength in this direction. You're going to notice a distal long head bicep tendon tear in supination or rotation. Proximally, we're all used to hearing about slap tears. These can be either acute or chronic. Distally, it's typically more of an acute event in the case of a traumatic or acute distal biceps tendon rupture. And as I mentioned previously, there's usually an element of degeneration. With respect to mechanism of injury, most patients will describe lifting something very heavy and oftentimes too heavy with their elbow at about 90 degrees. The heavy load then pushes their arm downwards as they're forcefully contracting. So you have an eccentric contraction, which overloads the capacity of the distal biceps tendon. The tendon subsequently ruptures, and then you get a Popeye deformity, which is that proximal migration of the muscle belly. And you can see this gentleman here, the middle-aged guy in the lower right, ruptured the right side. The left side is still intact. We see this in heavy laborers, bodybuilders, and it's generally men between the ages of 40 and 60. We talked about the presenting symptoms. Initially, it's an acute searing pain. This subsides within hours. Patients are generally left with a dull ache and activity-related pain, mostly with, again, supination, rotation. Weakness of flexion is generally not complained about. So with respect to the differential diagnosis, it's pretty obvious when you have that proximal migration of the muscle belly. But if patients complain of vague symptoms of cubital fossa pain, we have to include other diagnoses such as tendinosis. You could have a partial tear at the insertion with no retraction. And you could have, and this is somewhat rare, you could have entrapment of the lateral interbrachial cutaneous nerve. And that's sort of one of those zebras which you'll probably never see or might see once. So this is sort of a closer look at the anatomy of the cubital fossa. There's a lot going on. More superficially, if you can see this pointer here on the upper right, this is the biceps tendon. These are the two heads of the biceps. This is the lateral interbrachial cutaneous nerve right here. This little green structure is the bursal sac of the fossa. And if you look at this axial image or this sort of cross-sectional schematic here, you can see this green sac is snugged between the biceps tendon and the proximal radius. So with rotation, this bursal sac sort of gets pinched right here. And that can enlarge, and you can get sort of recurrent effusions and formations of cysts. And you can see that this is a pretty tight space. There's not a whole lot of room as your forearm rotates between the proximal radius and ulna. And the tendon actually is found to occupy up to 85% of the space between these two bones in your proximal forearm. So you don't have a whole lot of wiggle room, and it's very easy to develop a friction syndrome as a result of this. There is a classification scheme for a distal biceps tendon disease and ruptures. It's not really universally accepted or used all that often. It's pretty straightforward, though. When you rupture, you can either rupture where the tendon meets the bone at the radial tuberosity. That's an insertional rupture. You can have elongation or stretching of the tendon. That's an intrasubstance rupture or lengthening. You can have patients may present acutely or chronically. Anything greater than 4 weeks we consider to be chronic. And the role of the aponeurosis is actually quite important. The aponeurosis, which I'll show you in a later slide, is sort of a fibrous sheath which comes across the proximal medial aspect of the cubital fossa. So most patients with work-related injuries, chronic cubital fossa pain are going to end up getting an MRI. For a complete rupture, it's not necessary to make the diagnosis, but you're going to get it anyway for surgical planning because you want to evaluate sort of the condition of the tendon. This is an axial image of a forearm on the left side with a normal tendon insertion. So this is your radius, this is your ulna, and this black sort of semicircular structure is the biceps tendon wrapping around. On the right-hand side, you can see this increased fluid signal, which is represented by the white coloration here. And this is sort of a partial tear. The tendon is still attached, but you can see sort of striations of fluid intermixed with the black tendon. So that this would be an example of a partial tear with sort of intrasubstance degeneration. There may be elongation as well. You'd have to look at sort of a sagittal or coronal image to appreciate that. This is an example of a biceps tendon sheath, and this biceps tendon sheath cyst. This gentleman is actually about 22 years old. He was a nursing student who had had complaints of pain for 3 or 4 years, and he had gone through multiple bouts of physical therapy. He'd probably done between 9 and 12 months of formal structured therapy intermittently for several years before he presented to me. I injected him a couple of times because it was far enough away from the tendon that I thought that maybe we could get the swelling to go down, but it was resistant to that treatment, and we ended up making a small incision and debriding it. So these can be a problem, especially when they're loculated cysts like this, because it's a small space and it's very easy to develop a friction syndrome. Here's another image, sagittal plane, and this is the coronal plane. And you can just see this is your biceps tendon right here, and you can see the cyst adjacent to that, and it lies right between the tendon, and then this black structure here is the bone. So it's just sort of like a rotator cuff impingement of your subacromial bursa. So completely analogous to that. Here's another example, another image, an axial image of the cyst. So on physical examination, this gentleman here has a proximally migrated, completely ruptured tendon on the right. On the left-hand side, it's intact. So what you do, if everyone uses their index finger and sort of pulls across their elbow from lateral to medial, you can feel your biceps tendon at about 90 degrees. And if you flex your biceps, if we all have one, you'll feel resistance. Now, just because you feel resistance doesn't mean that the distal tendon is attached, but it means that it hasn't retracted, and it probably means that your lacertus fibrosus is intact. So here's the lacertus fibrosus. It's sort of this fascial band. The tendon is here, but the fascial band extends and inserts across the medial proximal forearm and inserts on your ulna. These are mirror images of one another. So here's the lacertus fibrosus. So you can have a distal rupture here on the lower right, but if your lacertus fibrosus is intact, it can sort of maintain the length of the tendon. So you can have a negative hook test, meaning the sign that the tendon's still there, but you can still have a tear distally. If you have a very more severe mechanism of injury, you rupture the lacertus as well as the distal biceps, then it's going to retract. So it's sort of like a check rein that prevents retraction, and its sort of physiologic function is just to protect the brachial artery, the median nerve, which lie underneath here. Many bad things on the medial aspect of the forearm. So hook test is what you do. It's not definitive to rule out a distal biceps tendon tear. So if a patient is getting sort of conservative management for what's thought to be just tendinosis, and they're not responding after 4 to 6 weeks or 8 weeks, you should get an MRI just to make sure that you don't have a partial tear, some tendinosis or degeneration. Plain radiographs are typically not that useful unless they're post-operative. Preoperatively, it's possible to have an avulsion fracture, but it's pretty rare. MRI is really where the money is for a distal biceps tendon disease. This is an MRI, sort of a sagittal image, and you can see here, this is the trochlear ulnar joint right here, the sort of the hinge joint of the elbow. And this is the front, this is the back, and you can see that this biceps tendon has retracted all the way into the cubital fossa, and this is skin right next to it. So you could probably feel that. You could palpate that tendon if you just put your finger on it. And it used to be attached all the way down there. So this is probably retracted about 8 centimeters or so. A tear like this, you definitely want to get to as soon as possible, preferably within a week or two. When you get to be over 4 weeks, the extent of retraction increases and the tissues begins to atrophy, and that can be a problem as far as your reconstructive or repair options. So why do these tears occur in the first place? We talked about the mechanical impingements. Here's the tendon again. This is the same image as you saw before. In full pronation, it occupies 85% of the space. So if you have a weightlifter with an increasing tuberosity size or tendon size, there's not a whole lot of room left there. And again, you get that mechanical impingement, degeneration, and subsequent rupture. It's also theorized that there's an element of hypovascularity. So you're just not getting enough blood to the tendon. That's also thought to be a role in rotator cuff pathology and Achilles tendon pathology. And there is a pretty good blood supply to the tendon. As that wanes in middle age, or if patients are smokers, or if they're subjecting themselves to supraphysiologic loads, that's when we run into problems. So in terms of management, if it's a complete rupture and it's a laborer or anyone who has any kind of sort of strenuous lifestyle, we definitely want to fix them. The sooner the better. With conservative management, patients lose 40% of their supination strength, which is quite significant, and they also lose 30% of their flexion strength. Following repair, they're close to 100%. They're 95, 97% normal with respect to strength. There are multiple variety of ways to fix distal biceps tendon tears. There are 1-incision techniques, 2-incision techniques, and they both have their pros and cons. This series of slides in the bottom right demonstrates my preferred approach, which is a small volar incision in the cubital fossa, and you can see that it's only 3 or 4 centimeters or so. You whip stitch the end of the tendon. Then you place a couple of anchors. You can see a button here, but you place a couple of anchors, buttons, or screw within the radial tuberosity, and you literally oppose the tendon to the bone and fix it with whatever construct you're most comfortable with. Both techniques work, and they both have their pros and cons, and I'll talk about those later. With respect to conservative managements, physical therapy, NSAIDs are probably a good starting point for partial tears or tendinosis. There aren't any good studies sort of proving the efficacy, but it's worth a shot, and you don't want to jump to surgery necessarily for someone who just has a partial tear if their symptoms might resolve after 4 to 6 weeks of conservative management. This photo on the bottom right is obviously staged because I don't think that most of our patients have this much fun in physical therapy. If you have a partial tear which doesn't respond to conservative management after 6 weeks, 3 months, or they're just getting worse with increasing activity levels, generally what we do is we detach it and reattach it in an anatomic fashion. Just debriding the frayed tendon, so if it's 20% or 50% torn, just going in there and cleaning it up doesn't really work that well. You have to take it down, reattach it, and generally what that does is it sort of reconstitutes a new blood supply through the healing process. You can get tendon elongation. So this is an example of a tendon, and you can see how there are sort of marker points along both sides of this tendon, and what's happened is it's stretched. So what you can do is you can release it and then sort of reapproximate them in a shorter position, and you just repair with suture side to side. This is less common. Usually you're seeing tears from the radial tuberosity. We talked about timing. If you're bringing someone to surgery after 3 or 4 weeks, you might want to have an allograft or plan for an autograft available because the MRIs are great for sort of diagnosing a complete tear, but it doesn't always speak to the quality of the tissue. So you don't want to be in a situation where you're there at the time of surgery and you don't have an allograft available, or you haven't consented the patient to harvest their semitendinosis. So you'd actually have to prep the knee out preoperatively if that was going to be your backup plan, if the patient didn't want an allograft. And this is here's a series of slides demonstrating the harvest site. You can take a semitendinosis graft from someone's knee through a 3 or 4 centimeter incision, so it's pretty cosmetic. And then this is an example of an allograft. And we use the semitendinosis tendon because it roughly approximates the size, shape, length of the distal biceps tendon. So with respect to the literature, and I'll just gloss over this briefly, if you do operate on patients between 1 month and 4 months, it doesn't seem to affect the outcomes. This is probably more in experts' hands. And it doesn't take into account the fact that there is a higher complication rate the longer you wait, because you have to do more surgical dissection. There's more morbidity. So if all else fails and you can't reconstruct the tendon, and patients are still complaining of pain in the cubital fossa, what you can do is you can grab the stump of the distal biceps tendon and you can just sew it to the brachialis. That's not going to restore any of the supination strength, because the tendon has to cross the joint and attach the proximal radius to supinate, but it might help with some of their cramping pain, and that's sort of the last-ditch technique available to us. The only patients who shouldn't have this fixed, meaning a complete tear, are those who are very sedentary or elderly or just not well enough to have the procedure done. Postoperative rehab is sort of probably the most important evolution or aspect of this talk. I like to protect patients for 8 or 9 weeks before progressing them to full motion and general strengthening. There are studies out there which suggest that you can move them actively right away, but that hasn't necessarily been as time tested. It's not as prevalently practiced. Most patients are getting protected in the early stages following a bicep tendon repair. With some of the newer modalities and fixation techniques like interference screws and flip buttons, it's probably okay to be a little bit more liberal, but in a workers' comp population, I tend to err on the conservative side. So this is the small incision that one uses, and there's a number of techniques. And at this point, I think I'm going to skip to a little animation. So this is obviously an elbow. This is the skin incision. It's minimally invasive, maybe 4 to 5 centimeters or so. You can see the lacertus fibrosus is still intact in this schematic. Now we're sort of resecting the shredded part of the tendon distally. You can whip stitch the tendon. And again, this is just illustrating various suture techniques. And this is where we're going to reinsert, right there where the stump is. So we drill a hole through the radial tuberosity, and this is a flip button or endo button technique. I don't think it really much matters which technique you employ. You can either use a button, you can use a screw, you can use suture anchors. I'm just showing you this particular slide because it gives you some idea or concepts of what's involved with the procedure. And orthopedics is just anatomy plus a little bit of common sense, so the tendon was torn from there, and that's where we're going to reimplant it. So this is sort of double fixation. So you have a button on the opposite side, and then you have a screw on the top side. So if you have double fixation like this, you probably can get away with moving them sooner than later. So the median nerve, the radial nerve, brachial artery, lateral interbrachial cutaneous nerve. So you really have to pay a lot of attention when you're doing this procedure. This is another slide on the technique, which we're now familiar with. If you do what you saw earlier was a one incision technique approaching everything from the front. Now that carries the risk of increased incidence of radial nerve palsy or injury. That's just coming from the top side. If you establish an incision on the top side and the back side, you're probably less likely to sustain an injury to the radial nerve. But if you take the wrong approach from the back side here underneath, if you don't come directly between the bones, and if you scythe off in this direction and you damage the periosteum of the ulna, what can happen is you can develop something called heterotopic ossification, or you can get bone that forms along the proximal aspect of the radial ulnar joint. So this is our objective, and this is a well-performed procedure with anchors which are placed within the tuberosity. This is sort of a cosmetic incision and a good functional outcome. We'll talk more about heterotopic ossification in a few minutes. So with the straightforward procedure, with no complications, we're splinting them immediately post-operatively. We talked about immediate range of motion. For 3 weeks, I like to maintain them in a splint. Between 3 and 6 weeks, we initiate physical therapy, and we can extend them to within 30 degrees of full extension. So I don't like to go past that point. If they have a really robust repair and they have better tissue quality, then maybe we'll advance them sooner. And again, this is sort of evidence to the point that medicine is not cookbook. Depending on the quality of the repair, you might advance them faster. But these are just general guidelines that we subscribe to. Between 6 and 9 weeks, we want to get to full extension. They still wear an immobilizer. It is unlocked, but they're still wearing it at all times. When they're 9 to 12 weeks, we discontinue the immobilizer, and we can start gentle strengthening exercises with a pound or two. Between 12 weeks and 6 months, you're just progressively increasing weight-bearing, weight-loading activities as tolerated. And at 5 months, if you're going to start work conditioning, this is probably an appropriate time point to do so. There's enough remodeling of the tendon that it can probably tolerate intensive exercise regimens. And then at 6 months, we clear patients to full duty. If someone has really robust tissue and a solid repair, full range of motion, full strength, maybe you can get them back by 5 months, but 6 months is probably the book answer. So nothing ruins a good operation like follow-up, and we do have complications with this procedure. There are two primary complications. One is that you can get development of that heterotopic ossification through the 2-incision technique. If you do the 1-incision technique, there's more retracting that has to occur, and sometimes you can sort of stretch the radial nerve, and patients can be left with the radial nerve palsy. If you're not sticking anything sharp down in that tunnel, you shouldn't cut the nerve, and usually this should come back. It can take between a month and 6 months, though, so we have to be very careful during the course of this operation. So I alluded to heterotopic ossification earlier. Post-operatively, it's important to get x-rays because you can see here this patient who was immobilized for 6 weeks, which is probably a little bit too long, started to develop some HO, or sort of lamellar bone within the soft tissues. If you get a CT scan of it here on the right, you can see a 3D reconstruction CT scan. You can see this big lobulated piece of bone. The HO can be so extensive they can actually fuse the two proximal bones together. So it's important to get these patients moving, and that's one of the reasons why we have these accelerated rehab protocols, is to sort of move patients sooner than later to avoid HO. You have to weigh and balance that against the fact that if the patient doesn't have great tissue, you may not want to move them for 3 weeks. So this is an axial CT scan. You can see actually the synostosis. So here's your radius and ulna, and you can see this bony bridge which has formed because this was probably a 2-incision technique where the ulnar cortex or periosteum was sort of excited by contact with the surgical field. There's other causes of HO: trauma, burns, neurological injury, and genetic disorders. If it's there, we generally try to cut it out. The timing of that is a little bit controversial. We used to get bone scans to see how metabolically active the synostosis was, or the heterotopic ossification was. You can base it on either a bone scan or radiographs, and it was thought that you wanted to wait for the bone to mature, but there's some evidence recently that going in there earlier results in adequate outcomes as long as you start physical therapy right away. Starting PT right away inhibits fibroblast formation and function and proliferation of scar tissue. And this is just a slide showing this block of bone that had to be cut out. This is the tendon, which was attenuated, and they had to revise the reconstruction with an allograft. If you're in a situation where you had to cut out heterotopic ossification, you don't want it to happen again. So what we do is we treat them with radiotherapy. It's an 8-grade dose. You can give it 4 hours preoperatively. Typically, it's done postoperatively within 72 hours. And what that does is actually it actually inhibits the function of the mesenchymal stem cells, which turn into osteoblasts and produce bone. So It's important to do the radiotherapy. It's the most effective way to prevent recurrence of the HO. It's very important to coordinate with the radiation oncologist preoperatively, a week or two in advance, because you want to get this scheduled within the 72-hour window. Otherwise, it loses its efficacy. You can also place patients on indomethacin, which is an NSAID, and this has also been shown to work by inhibiting prostaglandins. The neurological injury, other than the deep radial nerve or PIN injury, is the more superficially is the lateral intrabrachial cutaneous nerve, which you can nick, because if you remember that slide earlier, it runs right next to the biceps tendon. If you develop a neuroma and it's non-responsive to conservative management, you have to go back in there, find the neuroma, cut the nerve, and bury it in brachialis muscle tissue. So if you have a neuroma that's painful, you need to explore, isolate the nerve, excise the neuroma, and just literally plant the end of the nerve into muscle where it's not going to irritate anything or be irritated. We spoke about the posterior interosseous nerve. I just put this slide up to illustrate that it runs right here by the supinator muscle, which is next to the radial head in our operative field.